All right. Welcome, everybody. We are welcoming in. Sorry for the little bit of a delay opening up our waiting room, but we're glad you're here. So we're just going to give it a few minutes while everybody gets in. Excuse me. Okay. If you
While
are,
everyone's joining, I wondered if we wanted to ask everybody to answer something in chat.
yes, that'd be
That
great, Jan.
is whether your physician, nurse practitioner, whoever your primary care provider is, has ever checked your brain during your appointment.
Ever check? I'm typing it in here for you too.
All right. Has your provider, I should say, shouldn't say just doc. Never, no. Only when they suspected, I can't even get that word out, suspected a stroke. Don't think so. Nope, never found anything. My mom just said the other day, I had a brain MRI of my head and they found nothing. So hopefully they found
Julia said, should they? Should they? I'm like, we're going to
should
answer that
they?
question today. That's great. Yeah, Olivia said, yeah, she's had testing done, but otherwise, other than the formal testing, nope.
Okay.
Awesome. All right. Well, we're getting our numbers up. We had about 150 sign up. So right now we have 98. I will get started introducing some of the stuff soon so that we can be prompt.
Yeah, looks like Melissa has had her brain checked. That's good. I like it.
Oh,
So
all right,
one out of
Melissa.
about 30 that have answered. That's not the best odds. And I'll say that Ohio is pretty good compared to other places. So imagine what the
Yeah.
rest of the world is.
Wow, that's great. Okay. Well, if you're here for exploring a new resource for dementia in adults with intellectual and developmental disabilities, you are in the right place. OECB is super excited today to welcome Jen Pettis from the Gerontological Society of America. I'll tell you a little more about her in a minute. Just a few housekeeping matters before we get started. This is a Zoom webinar, so you will be able to see myself and Jen if we have our cameras on. We cannot see you or hear you, but we really are glad you're here. We are happy to take questions in the Q&A. If you look down at the bottom of your screen, just to the right of the to the right of your options, it says Q&A, and you can put your questions in there. If you see somebody else's question that you think, wow, that was a great question, and you want to give it a thumbs up, there is an option to give it a thumbs up, and that will prioritize our question. I will be helping Jen to take some of those questions, and I will answer the really easy ones, but like really easy. Jen will handle the harder questions. And if you just want to comment, like you guys have been, about things that Jen might ask you or I might ask you, or you want to see if somebody is in the crowd, feel free to put things in the chat box, which again is more towards the left. Just for you guys' information, we have about 150 people sign up for this session today, so we're super excited. And we hope to get close to that in the group because I know you don't know how many people are here. If you are, obviously you're attending the SSA summer series. This is our second session. And Jen has been on my radar for this for a long, long time. Jen and I have worked together. There is 2 more sessions in the SSA summer series. Next week we have a session around supported decision making throughout the lifespan for people with intellectual and developmental disabilities. And then the following week, the last week of July, we have assessment versus assessing by O'Calley that are going to talk about that. So spread the word, tell your friends, sign up if you haven't signed up yet. Please try to make it to all our sessions. We're really excited. And CPDUs are available for this session. You don't have to do anything in the next day or two. You will, if you logged in with the same email that you registered with, you will be checked in, and you'll get an email that says that CPDUs are ready to be collected, and you'll fill out an evaluation, and then you'll get it. If you have any problems with that, you can email training at oacbdd.org, and they will help you, or you can email me directly because I love to get in there and do that kind of work instead of like talking about policy and rules. So feel free, whatever, I will help you. All right. Well, we got a good portion of our folks in here. For those of you who came in a little bit later, we put a question in the chat box. Jen wanted to know if any of your primary care providers have checked how your brain is doing lately. So that is what all these comments are. Feel free to add that in. And on that note, I think we're going to go ahead and get started. Remember that you can opt for closed captioning if that helps you. We are recording the session also, and we will be sharing out a PDF of the slides and potentially a recording of the session. But Jen's going to let you know she would love to come and talk to all of you anytime, especially virtually. So you don't really have to watch a recording. You can just invite Jen, and she's amazing. So, all right, Jen Pettis, one of my favorite people that I've met I think we met in 2023. And we got to eat a lot of meals together, and we're both foodies. So that's what I know about Jen Pettis, is that we like to talk about good food together and good restaurants. But she is extremely knowledgeable and coming to us from the Gerontological Society of America. And she is an awesome resource for information and is going to share this awesome stuff that OACB worked with her and a lot of really great people on. So on that note, Jen, I'm turning it over to you.
All right, sounds good. Well, thanks everyone for answering my question. I love to start with that question because I think it's just kind of a check in time of like, ooh, why aren't we checking our brains? It's like running everything else. Why aren't we taking a look at that? And so I'm here to talk with you today about this new resource for dementia in adults with intellectual and developmental disabilities. I want to give you my full disclosure that I'm a registered nurse who's worked with older adults for over 30 years, whether it's through direct care or policy or teaching and training or resource development or whatever it might be. I am not an expert in IDD, but I know a lot of people who are and who collaborated with us on this great new resource. In just a moment, I'll tell you who Gerontological Society of America is as well, so you'll have that context. So our goals for today are, first, we're going to talk about some basic, what does it mean when you have changes in your brain that are kind of normal for aging, and how do those compare with changes with dementia? We'll look at ways to promote brain health regardless of your age. Basically, if it's good for your heart, it's good for your brain. But again, we need to raise the awareness of how critical that is. I'll define for you this GSA KAER, K-A-E-R framework, and describe the benefits of that framework. And then I'll share some tools and resources in the KAER Toolkit. And in a moment, I'll tell you kind of where that KAER Toolkit started and where it's progressed to now. And then we'll look at this new resource that really does have roots in Ohio. It was launched in Ohio, and it's gotten some really tremendous traction in Ohio. And it is called Addressing Brain Health in Adults with Intellectual Disabilities and Developmental Disabilities, a companion to the KAER Toolkit for primary care providers. And so let's start with that kind of basic information about what's it like to have normal age-related changes versus when you might have, someone might be experiencing dementia or Alzheimer's. So we often think of dementia or Alzheimer's first off about memory loss, but it's really important to note that while this is a common sign of Alzheimer's or dementia, and you can think about dementia as kind of this umbrella term, and then there's lots of types of dementia that are kind of spokes underneath that umbrella. And Alzheimer's is one of the largest groups of the most common dementias, I should say. So really the largest bucket underneath that umbrella of dementias. So it is common to have memory loss in dementia, but it's not uncommon as we age, or for any of us, frankly, to have occasionally forget things, a name, an appointment. But then we go, oh my gosh, I forgot that appointment that I was supposed to be at this morning. You kind of get sidetracked, do other things, or you're like, gosh, I know that face, I can't remember their name. And then you're like, it starts with K. Oh, that's the name. Someone with dementia is not doing that. Instead, they're early on beginning to write sticky notes. They're beginning to ask the same question over. Did we eat breakfast? Did we eat yet? Did we eat yet? What are we having for lunch? What are you having for lunch? Or they might ask about a recent event, but ask the same question over and over. Someone with dementia may have difficulty completing things that are familiar. They can no longer play their favorite card game. They can't make a grocery list. They can't write checks. They may not be able to figure out how to manage a part of their personal care versus someone who has, any of us, again, regardless of age, we might occasionally need help with setting up a new appliance or setting up a new electronic device. Planning and problem solving definitely becomes a big issue for for people with dementia or Alzheimer's. And so looking at the ability to really plan and problem solve, unable to maintain a budget, unable to follow a recipe. We also may get folks that are extremely susceptible to scams. Again, very common because of inability to really make the decisions, making sound decisions, versus we occasionally miss a payment on something. Everybody has done that. Confusion to time and place. So I might show up, if I have Alzheimer's, I might show up instead of shorts and a t-shirt in this weather. I might be bundled up because I just have no idea of how hot it is out because I don't know the season at all. They forgot where they went somewhere. We hear all the time on the radio, someone, a missing older adult. Every state calls them silver alerts or, pewter alerts or whatever they're called. And it means a missing older adult or vulnerable older adult. And so folks might get somewhere and completely forget how they got there versus we forget what day of the week, especially a holiday week or when we're traveling or something. We have no idea what day of the week it is because we haven't had to figure it out. With someone with dementia, they may have trouble with words. They really can't maintain a conversation. They're unable to name familiar things, or they're having totally nonsensical speech sometimes versus we forget that one thing we're thinking of when we're trying to name a particular device or something like that. It's very usual for people who, as they age, to have that loss of ability to see close up. There's definitely a reason why you see older adults wearing bifocals more than you see younger adults. And that is we don't have that near vision anymore, the fine print. When someone with dementia or Alzheimer's has changes with their vision, very often it's either they can't understand the image they're seeing, or they have this very strange relationship with their spatial kind of vision, their spatial understanding of what's around them. It's not uncommon for someone with Alzheimer's to reach into their closet to get something and kind of fall into the closet. Or you might see a person with more advanced Alzheimer's in particular, if there's one of those floors that have like white spots, but then an occasional black spot, they'll look to step over that black spot because it looks like it's a hollow thing for them. It looks like it's a hole for them. They don't have the spatial recognition of really where that depth is. They have, again, decreased judgment, changes in grooming. Someone who's usually very well groomed suddenly is not willing to take a bath or not willing to get their hair done, versus we occasionally make a bad decision. Every one of us has wore our pajamas on Saturday morning until it's time to take a shower and put your clean pajamas on Saturday night. That is an occasional bad decision. If we do that day after day, it's a problem with our thinking and reasoning. They withdraw from work or social activities. They're not engaging in their favorite hobbies. They just can't engage in the things they used to. Someone who talked in a webinar or a podcast with us about her husband, talked about him usually working the room. He would go in and just brought people together. He was a golfer. He had people who always looked to him to be like the social leader, and he just lost his abilities to do that. Then there's also these, the typical age-related changes of sometimes you just don't feel like going to and attending a family event or social. We all have that regardless of our age. My husband has a shirt with a brown M&M on it that says, "I'm sorry I'm late. I didn't want to come." And I always think of that when I see this typical age-related change. Again, it happens at any age. And then the last symptom is changes in mood or personality. And this is beyond we become annoyed when our usual routine is disrupted. It's not uncommon. We get what people might refer to as set in our ways. That's very common, particularly as we get older. They want a very particular thing. My mom's a great example. She gets up at a terrible hour of the morning, about 5:30 in the morning, even though she's retired, has her breakfast, feeds her birds, does all her stuff. They have their yogurt and coffee at 10 a.m. on the button. Again, that's her usual routine. The difference when someone has Alzheimer's or dementia is they're having mood or personality changes. It's not just that they're irritable if their mood is disrupted. It's that they're suspicious. They're saying someone has stolen something. They're anxious. Someone's out to get them. They're afraid to go outside. Maybe they see that there's a shadow or something, and they're certain that it's a man outside their house looking to get in. Someone saying this slide makes them feel so much better, right? We all do those things on the right, but it really helps us understand when we have to be concerned. And I love this one's just glad that his dad or their dad is just a regular grumpy old man. Again, nothing wrong with that. So then what do we do to stop that? We're learning more and more about Alzheimer's and dementia and how much is really preventable. They say about 40% of dementia is preventable. We know that things like hearing, if you have hearing loss and don't wear a hearing aid, this is really a profound impact on your brain. But we also know there's just a lot of brain healthy habits that everybody can adopt regardless of the stage of life. And the first is to break a sweat, to engage in regular cardiovascular exercise. Things that elevate the heart rate, increases the blood flow to the brain and the body. So it's not just counting steps, but it's really picking up the pace and getting those steps in with that regular cardiovascular exercise. And the other thing I'll mention, just as we age, it's so important to, in addition to getting that cardiovascular exercise, that we're getting a couple of days of resistance training exercise. We're really looking at maintaining muscle and also focusing on how important balance is for us as we age. And then hitting the books. Participating in formal education at any stage of life is going to reduce your risk of cognitive decline and dementia. Challenging and activating your mind, whether you build furniture, complete jigsaw puzzles, do something artistic, play games like bridge, or I do the Wordle every morning, something that makes your brain think. And then quitting smoking. We know that quitting smoking can reduce the risk of, well, I will say that smoking increases the risk of cognitive decline. We know that. And then quitting smoking can actually bring that risk back down. So it really cannot even just like level off your risk, but actually reduce that risk. And then follow your heart. Keep a check on risk factors for cardiovascular disease and stroke. Excuse me, these are things like obesity, high blood pressure, diabetes. All of these cardiovascular risks also impact your brain. And then keeping your head or brain safe. And you think, well, that sounds so easy, but things like wearing a helmet when you're riding a bike or playing contact sports, taking steps to prevent falls, wearing a seatbelt. Brain injury is going to drastically raise your risk of cognitive decline. I think back to when I was a kid, I can remember learning to ride my bike, hands-free. And every night for like 2 weeks, my parents would hear me coming down the little tiny hill in front of my house and crash. And I crashed, and we never wore bike helmets. They weren't even a thing. But we know, again, that are so important, and we see them more and more. And then eating right. We know that certain diets really impact cognitive functioning. Things like the DASH diet or the Mediterranean diet, or what we call the MIND diet. And what those diets really all have in common is that they're lean animal proteins. They're high in grains and low in saturated fats. The fats that they are included are healthy fats. There's things like nuts, seeds, lots of veggies and fruits. So again, all of those, and again, limiting processed foods and salts and all of that. Make sure you get enough sleep, and then take care of your mental health, looking at things like depression, anxiety, or other mental health concerns, and try to manage stress, which we know is easier said than done, but look to ways to do that. And then buddy up, stay socially engaged, pursue social activities that are meaningful for you. If you like animals, volunteer with animals. If you like to sing, join the choir. Again, sharing activities with family and friends, things that you find meaningful. All of these are so important. And we really saw how impactful loneliness is as we went through the COVID-19 pandemic. We saw what a crisis it was for older adults to be so very lonely. And so I'm going to do here what you usually don't do when you're giving a presentation, is that is invite someone to get out their phone and scroll along. So we do have all of these resources are on our brain health website. It's www.geron.org brain health. And you can just get that right at that QR code. And Lisa has shared these PDFs of these slides. So you'll have this QR code if you prefer to take a look after. But Lisa let you know I'm from the Gerontological Society of America, or GSA. And you may or may not have heard us. My guess is most people on the phone haven't, but who are we? We are a professional society, and we are the largest and the oldest. We're going to turn 80, I believe, this year or next year. We're the largest professional society that's really dedicated to advancing innovation on aging across the lifespan. We have about 5,500 members that come from 26 different disciplines. And that to me is the sweet sauce of GSA. I'm a nurse, but I don't just talk to my nurse friends at GSA. I talk to my doctor friends, my social worker friends, the people who are zoologists, the people who are biologists. Some might study human-animal interaction or transportation and aging. So we're really able to get this kind of 360-degree view of aging across the lifespan, and particularly for care of older adults. So we really have 4 big buckets of work at GSA. We focus a lot on research. We are a research society for sure. We have a lot of caregivers, people who provide direct care. They usually are also researching that care as well. We advocate for important policies that advance the meaningful lives as we age, which is our vision. And those policies are things like coverage for vaccines for older adults, for any recommended CDC recommended vaccine. We educate the next generation of aging experts, and we also seek to make higher education, institutions of higher education, much more age inclusive, whether someone is an older learner, an older worker, an older faculty, whatever it might be. And we really do focus on diversity, equity, inclusion, and accessibility as fundamental principles in our society. And so why are we here talking about this CARE toolkit? Back in 2013, the Centers for Medicare and Medicaid Services approached GSA, I'm sorry, to let them know that the annual wellness visit for older adults was not really being used. And what the work group pulled everybody together and said, failure to use this annual wellness visit is really contributing, and the annual wellness visit could really kind of combat this serious but frequently overlooked gap in healthcare. And that is how older adults at risk for or with signs and symptoms of Alzheimer's or related dementia aren't really diagnosed. They're not assessed for that during their routine visits with their doctors. The bottom line is none of you guys, or most of you guys, have not had your brain checked, and most older adults weren't getting theirs checked either. So GSA pulled together this work group, and in 2015, they issued this publication that was about recommendations, a report and recommendations from the work group on cognitive impairment, detection, and earlier diagnosis of dementia. And so that included some recommendations, and it included this CARE framework, which I'm going to tell you more about in just a moment. And then in 2017, GSA said, well, let's give folks a toolkit, the tools and resources they need to implement better care for older adults and screening for brain health. And so that first kit launched in 2017. It was updated to its current form, which is a PDF. The first one was like a binder with everything in it. The next one became a PDF with links that go out into other resources. And then that was updated in 2020. And we are just in the final review of a kit that will launch on the 1st of August. And that is a fully online web-based brain health toolkit. So we're really excited about that. And again, that'll be watch for a press release from GSA on that. And it will come out, like I said, around the 1st of August. When you think about dementia and you think about the chronic disease of obesity, there's a lot in common in the primary care setting. Nobody wants to talk about the two conditions, whether the patient or the provider. There's a lot of just kind of throwing your hands up and saying, what am I going to do anyway? Why do I need to talk about this? And there's a whole lot of confusion and mystery about the two conditions. So in 2022, GSA applied the CARE framework to the chronic disease of obesity and launched a CARE toolkit for obesity. And then we were really excited in 2023, we began the work on and launched in 2024, this new CARE IDD companion. And that is what we're really here to focus on today. So what is this framework? The CARE toolkit or the CARE framework is kickstart the conversation. So in the brain health toolkit, kickstart a brain health conversation, assess for cognitive impairment, evaluate for dementia, and refer to community resources. And so it's all about talking about brain health, assessing using some standardized tools for, does the individual have potentially have dementia based on the findings of these screenings? And if they do, evaluate for that dementia and then refer them and their families to supports that can help them maintain their function and well-being as long as possible in the setting in which they choose to live. And this toolkit is really intended to be as a supportive document of practical approaches, educational resources, and validated clinical tools to help teams implement this framework in their own practice. So the toolkit was really developed with the primary care team as a principal audience. However, we know that lots of communities of interest will find its content useful as they work to really improve practices around brain health. And honestly, there's a whole lot of resources for individuals in there, like those first few slides that I shared with you. So current key features of the toolkit, it is, again, right now it's electronic, but it's moving to fully online. There's really the 4 main sections associated with each letter, and each has key section takeaways. We have ways to get paid for care-based care. We also have some practice management tools coming out in the new one. They're how to communicate information about communicating effectively with older adults. Most of the resources and tools in this are not GSA's resources. Rather, we pulled together an expert advisory panel to really build on this to say, let's look at the best of everything out there that's evidence-based, and then really come together and bring those resources all to one place. And we do have additional resources that address brain health that are really branches. But we're really here to focus on this today, the addressing brain health in adults with intellectual development disabilities and developmental disabilities. This is meant to be a companion to the main CARE toolkit, but it really serves really the unique needs of individuals, of primary care providers who are working with individuals who have these underlying conditions, as they potentially have signs for dementia, or perhaps they have something that looks like dementia that really isn't, and we'll talk more about that. And so to address the needs of adults with IDD who develop dementia, the goals of this companion are to raise awareness of the unique needs with adults with living with IDD, equip and encourage caregivers and healthcare teams to engage in appropriate conversations with those individuals and their caregivers, and promote brain health conversations that really focus on early detections of changes in cognitive and adaptive functioning with older adults. So we're really looking at how is their overall functioning changing in the adults with IDD, and then assisting with the identification of community supports and resources aimed at enhancing function and quality of life for adults with dementia and IDD. It's really important to mention here, as I've trained some community or some county boards of developmental disability on this resource, they've actually invited in their county boards on aging. And it's kind of represented in many cases the first time that these counties have learned, these two entities have learned together. I've always worked in the aging space, I mentioned that, but I had the opportunity to go to the OACB convention a year or so ago, or almost a year ago now. And when we looked at the use of technology in the IDD community is so much more advanced than it is in the older adult community. There's just such an opportunity for this cross collaboration and really bringing the best of both kind of home and community-based services together. It really is, it's really enlightening and awesome to see that. One of the things that really struck me when I spoke to someone at the Developmental Disability Conference was they were doing this kind of group respite where someone, it reminded me of when I had watched heart monitors as a young nurse. You were one nurse in a room with like 20 heart monitors. Well, in this case, they were doing long distance respite care where they had cameras in a couple of areas in the person's house. And it was someone who was relatively, safe and, but could be monitored from afar. And they actually worked with having one caregiver monitor like 6 or 8 different cameras. And so what a different way to use resources much more efficiently. It was just super exciting to see that kind of thing. And it seems like such a super opportunity to learn from each other. So
Jen, listen to you talking about our remote support vendors and all that. That's who it was. So
they're
yeah, you're
awesome.
right.
And
Yeah, and
one
it could be
thing,
something very collaborative with aging that they could start looking at a potential instead of
yep,
just emergency response systems. So, we all used to use emergency response systems, but this is more support than that. So
yeah, yeah, very,
thanks for learning while you're with us.
yeah, it was very cool. I was like, why are we not doing that in elder care of older adults? All right, so in the first section, which is just kind of the introduction, we do have a table that gives a summary of dementia characteristics in adults with IDD or other neurotypical conditions. So what we look at here is how does their risk for dementia compare with the general population? If they were to get dementia, what is likely the type? What are some risk features? What might cause that? And what are associated things that you might see, associated symptoms? So just a really nice overview table. And so let's think first about the CARE framework and that toolkit. So that initial brain health toolkit. The first step of that toolkit is to kickstart the brain health conversation. And this is where providers discuss brain health, them and their teams observe for signs and symptoms of cognitive health that may require additional evaluation. They actively listen for patient and family concerns. And the tools in this and resources in this section really help focus, help the provider teams to address any sensory losses and apply the effective communication strategies. There's tools and strategies to assess for hearing and vision loss and a checklist to support providers to address that sensory loss. They focus on raising the topic of brain health. We include some tables around here with like key messages around brain health and resources for brain health for patients. So again, things that all of you could use for your families and friends and things. And then we, again, ask about memory and cognition. We listen for concerns. There's a great video with one of our panelists from the Alzheimer's Association where he's talking to a patient and really asking about how they're feeling about their thinking. So asking questions, not just, do you think you have dementia, but are you having any changes in your memory or thinking? Listen for families' concerns. More than a third of patients age 65 or older are actually routinely joined at their provider by a friend, a neighbor, a family member. So talking to those people as they're in the office. Them looking for signs of symptoms. We do have a nice table that indicates when someone might have dementia. It would be great to ask a question on health risk questionnaires and kind of intake questionnaires and use electronic health records. Teams might look at someone's having new falls or needing more help with activities of daily living, or maybe forgetting to take medicine, and those things appear in the electronic medical record. Those might be potential flags. And this is just an example of key messages about brain aging. So our brains do age just like every other part of our body. And cognitive aging is not dementia. Again, there's some resources in our toolkit about cognitive aging. And we do have some really great momentum discussion podcast. If you just Google GSA Momentum Discussion Podcast, you'll find a whole bunch of them. Again, really exciting stuff in there. There's always brand new news in the podcast. And then again, just another example, we've got some Kickstart resources for brain health for patients. And so what is the new Kickstart, the companion ad? It is really all about when communicating with the adults with IDD, healthcare providers should use strategies and language that individual is able to comprehend, and again, incorporating caregivers in the conversation. And then looking at having those conversations on an ongoing basis. And that will include the regular assessments of cognitive and functional status to really gather baseline information. We talk about compiling a life story, and that can be used as a resource. And we can, the providers can be telling caregivers, family caregivers, whoever, to really create a baseline video diary with the adults, speaking, interacting with others, performing fine and gross motor skills, and otherwise engaging in activities that reflect their talents and abilities and the uniqueness of that individual. And we always want to incorporate person first, or disability inclusive person first language. Whoops. And next, we assess for cognitive impairment in the CARE framework. And this includes using brief, structured cognitive tests and other assessments to detect cognitive impairment in a timely way, with the goal that if something is found, then determining if that further evaluation is needed. And we really stress in here that this is not just a, it would be nice if the whole team participates. It is essential that the whole team participates in this. And so what are the approaches to implement using a validated cognitive test? So we use things like in the general population, things like the mini-cog or the Montreal Cognitive or MoCA questionnaire. So lots of different questionnaires, but there also are questionnaires to obtain family perceptions and the individual's perceptions. And we, again, to have office staff participate. We know that it's perfectly acceptable and very routine practice in some places to have medical assistants do these tests. I actually talked to a colleague out in the Cleveland area, and they had told us they had about 48,000, I think, 48. Anyway, they had a ton of screens being done by medical assistants each month. It was really amazing what they had been doing. And when we talk about the brief cognitive screening tests, we do focus on those that are available in other languages. I think it's always important to consider that things that have been translated have not necessarily been adapted for a particular population. So that is important. And then we also list the family informant questionnaires and the self-report questionnaires. And so what does the IDD toolkit add to this? We know that there are lots of barriers that an individual with IDD and their caregivers face when trying to obtain an accurate assessment of cognitive impairment. And unfortunately, that new cognitive impairment or that change in function might be automatically attributed to their underlying disease. Then we know that assessments are going to be complicated by perhaps cognitive impairments or other challenges like sensory impairments. So it's really important that we avoid what we call diagnostic overshadowing, or automatically attributing that behavior or that change to their underlying disability. Or kind of the reverse of that, because they have the underlying disability, that they automatically say that when they're of a certain age, well, they must have dementia. They must have Alzheimer's because they have Down syndrome and they're in their 60s. So we want to avoid that as well. And we want to make sure when something, a standard assessment can just be adapted, like made large print or using assisted living devices or something like that, then it's, we want to, again, make those accommodations. Using those longitudinal assessments is really important so that we can understand the trajectory over time. It's important to use cognitive assessment tools specifically developed in individuals with IDD. And I'll show you a lot of those. The NTG Early Detection Screen for Dementia, or NTG EDSD, is one of those. And then again, capturing information about personal history including key events and things that might be causing changes. One of the stories that really inspired me to seek a grant to support the development of this kit was one of my nurse friends told me a story that exactly what I just described to you happened, where they automatically attributed someone having a change in function to a diagnosis of dementia. It was an individual with Down syndrome. They had lived in their in a very large institutional setting for a very long time. And they moved to a community group home, which all of us thought, wow, that sounds like a great change. The problem is they had lived at this other place their whole life. It was all they knew. Their friends were there. All of that was there. So while this person had been diagnosed over the phone with dementia from their primary care provider, the nurse practitioner, who's got a lot of experience, actually only experience in IDD, went in to see that patient in the group home. They said, you know, this person is profoundly depressed. They miss their home. And so what they were able to do is treat that depression and reverse those declines for the resident. And so we do have recommendations for what assessments work best and whether they, you know, how often they are done, whether they need to be adapted, what are their barriers, and is it useful or essential that an informant is also involved. And next we evaluate for dementia. That is the third step, where we talk about how important it is to have that diagnostic evaluation, to have that conversation with the patient, and then rule out reversible causes. When you think about the diagnosis of dementia, it is a diagnosis of exclusion. You've ruled everything else out, and you say, yes, they do. In fact, we believe they have dementia. And then from there, you determine what type of dementia. So the steps in this section are really in supporting the individuals and their family to understand why it's so important to have that conversation, to have that diagnostic evaluation. And then the primary care doc can conduct that. We do list in the care toolkit certain times that a referral to a specialist is appropriate, but we really do believe that making a diagnosis of dementia is fits firmly in the primary care space. They just can't, you simply cannot send everybody who has a change in thinking to a neurologist. Identify the cause, so the type of dementia, then disclose that diagnosis. There's some really great resources to support conversations around disclosing that diagnosis. And then when indicated, also disclose it to a family member or trusted friend. This evaluate table, which is components of a diagnostic evaluation for dementia, is probably my favorite resource in the whole toolkit. We also do have some real specific resources around pseudobulbar affect, dementia-related psychosis, and agitation and Alzheimer's. Particularly the agitation and Alzheimer's has a lot of really great information about managing behaviors associated with dementia. It's really got some great information for regardless of the setting in which you work. And then again, there's tools that help. The resources I'm showing here are specifically linked to resources addressing Alzheimer's, vascular dementia, Lewy body dementia. Really, they're intended to help the primary care teams make that differential diagnosis. And then again, resources on the disclosure. And when we look at what the evaluate part of this toolkit adds, it's really about laying out the components of that complete diagnosis, that thorough evaluation to determine the diagnosis. So we talk about a decline in function or change in behavior could be due to a lot of things, but we look at like other diseases, adverse events to medications, sensory problems, physical changes, nutritional changes, thyroid problems, you know, all of these different things that we want to make sure we're ruling out and addressing all these things. Again, we want to avoid that diagnostic overshadowing that I mentioned. And then if we do identify some of these other conditions, are they amenable to treatment that can reverse the declines? And then again, consider that a full range of issues in addition to physical and cognitive exam. And so we do have the conditions that can cause memory loss. So just a nice kind of list of, hey, have you considered this for that person? and then the components of the evaluation for dementia in adults with IDD. So we talk about medical and psychiatric history, historical description of baseline functioning, focused review of systems, family history, all of these things. And then there's really quite a large inventory of the different dementia screening and assessment tools for adults with IDD. Really a nice bucket of different resources here. And we talk about the strengths and weaknesses and give a description of them. And then we want to, in the final step, refer for community supports. And so we often get the question, why do we want to get an early diagnosis of dementia? What are we going to do anyway? And this answers that, what are you going to do anyway? It's all about wrapping the individual in supports and services to help them maintain their function as long as they can in the least restrictive setting in which they want to live. And so it's all about having internal staff, but also community agencies and really connecting them with their loved ones. This is a big part. You may have heard about the new guide model from CMS. The new guide model is an alternate payment, a demonstration. And a big part of that is supports and services and follow-up. And then providing education, support, and referrals. We know that the receptiveness to education and referrals changes over time. So it certainly shouldn't be a one and done conversation. And then we should encourage participation in clinical trials. And so again, we're doing that regular follow-up. And I've mentioned all of the other things on this slide already. The one thing I do want to mention is we have a webinar on this, and it's a podcast. I'll actually show it on the next slide. It's our colleagues at Emory Integrated Memory Care, which is a nurse-led primary care clinic, the only one of its kind that has terrific outcomes, and they're just doing amazing work down in Georgia. And they use a risk-based approach to referrals. They really conduct that comprehensive assessment, and then their care planning is led by whatever team member is most appropriate to address the largest challenges for the patient and their care partner, and then making those external referrals. So it might be a nurse one time, and it might be the social worker one time, it might be a psychiatric nurse practitioner another time. So it's all about the person most appropriate to meet the care needs of the individual. There's a real nice referral form in the CARE Toolkit. And then that momentum discussion podcast that I mentioned, I have a lot of favorites, but this is definitely one of them, and it's interdisciplinary approach to community referrals. It's with Dr. Carolyn Clevenger and Laura Metters, who's a social worker, a nurse and a social worker. They're terrific. And so what is our new refer concepts in the IDD companion? Again, it's all about once that referral is being made, to ensure that that individual with dementia and their caregivers receive the appropriate post-diagnostic supports and services. So we're making those referrals, and we're sharing the diagnosis with other entities who may be involved. And then we're adapting the care approaches that are used for the general population to meet that individual's needs, and then conducting individualized care planning for the dementia as well as their other diagnoses. And just some of the tools and resources here, the post-diagnostic support. So we talk about what do we do immediately post-diagnosis versus what do we do further on as ongoing, and then when someone's in advanced dementia. And then strategies for managing the dementia in adults with IDD. Again, we're looking at what do we do pre-diagnosis, what do we do during the time of diagnosis, post-diagnosis. So really looking at different stages. So that's really a high flyover to toolkits. I want to acknowledge extensive acknowledgements and appreciation. First is to our collaborating organizations. We collaborated with the National Task Group on Intellectual Disabilities and Dementia Practices, the Ohio Council for Cognitive Health, and the OACB. And their Lisa was one of our expert advisory panels, along with our colleagues from Ohio Council for Cognitive Health and the NTG. And we did receive support from AZI for this, to develop this resource. And with that, I'm going to ask if you have any questions. My email is there. I welcome an email from you. And I am going to stop sharing. And
awesome. Well, I don't know if you have a colleague on here or not, Jen.
I was just answering in the chat. Ophira, yep.
Yeah, there's a great There was a great question answered that we already put under answered, which you guys should be able to see. That says, do you have resources that show the correlation between untreated hearing loss and dementia? And it's Ophira
Yeah.
answered with 2 of them. I didn't know if you wanted to expand on that anymore or.
Yep. So on our brain health website, we have a podcast with Dr. Frank Lynn. Afira, could you go to the actual podcast and grab it from Podbeam as well, or chat in the momentum discussion section of the GSA Enrich? And then the public health, the resource that she included there is a piece from Dr. Lynn. Dr. Lynn's like the leader of this. He's out at Johns Hopkins University.
I was going to say, when I searched it, something about Dr. Lynn and John Hopkins was the first one that came up. So that looks terrific. Like it was a pretty exciting study that they did. And then in the chat box, Ophira just put that in there. So by all means, you guys answered that question well. While everybody's thinking of other questions, I think this is a great one, and one that Jen and I have talked about on a regular basis, and that's, will all physicians in Ohio be provided with a copy of the care guide for IDD? So Jen, what do you want to say about that?
We have some physical copies. So we have handed some of those out in Ohio. What I would encourage all of you to do is to bring the care toolkit electronically, share the QR code, share it with everyone. It really is intended to be an electronic resource. So we're definitely doing our part to get it out there. We have spoke to some physician groups in Ohio. I presented at the Ohio Healthcare Association's conference, to the think tank there, the Equity Think Tank in Ohio. This toolkit is being used along with our regular care toolkit as part of a couple of statewide grants in Ohio. One that's being led by the principal investigators at the College of Nursing at Ohio State University. I know it's being used in one of the works in a particular county out there. I don't know if that's fully fleshed out yet, so I'm not going to share which county. But Ohio is, several groups in Ohio are very strong collaborators with GSA. Anyone who becomes a dementia-friendly community in Ohio has to use the care toolkit in some way in order to become dementia friendly. So Ohio is all in on the care toolkit and this new IDD resource.
Yeah, this is really quite new. I mean, I'm gonna say, I think Andrea who asked the question, but we really are depending on the awesome folks in Ohio to really kind of get that word out. You know, share with your families that you're working with. You know, obviously people with disabilities. You know, if you find yourself, share with DSPs who are taking people to doctor's appointments for them to bring it and say, we'd really like to start talking about this and utilizing it. But it is a very new resource. And even the care toolkit, let alone the companion, as you guys noticed in your chat, is not necessarily being used all over the place like we would like it to be. So by all means, Ohio has an opportunity to really stand out here and get it out, and then we'll have more opportunities. Corey did a follow-up question to the one prior, in that, is there training available for actual providers, care providers, if somebody wanted that, Jen?
So we're happy to present this to different provider groups and things like that. We seek opportunities to do that all the time. So if you are connected with a group of providers that would like a webinar, or has a conference or something, we're happy to do that. We do have different podcasts and different other things to really talk about the resources, but we don't have a particular training on this one in particular. The regular care toolkit, we have a lot more resources around, only because this one is so very new.
Awesome. Thank you so much, Jen. All right, let's give her some more questions for you, because I really think this is an interesting topic, and I know we are not medical professionals that are on this call. We are SSAs. So I am happy to hear ideas or connections for ways that you think we could get this out to people. But I really think it's about that self advocacy. You know, every one of you think about for yourself. How would you go about advocating to your family care provider to start checking in with you about brain stuff? Because this is my struggle. Um, Also, they were wondering if we have any trainings or would we be available to make them specifically for families of individuals with IDD, Jen. That just came in the Q&A.
So one thing I would say is use the first 3 slides in this deck where it's the normal brain changes versus not, and the 10 things you can do to help keep your brain healthy. We should be talking to everybody about that, even younger people. Let's talk about that. So there is not specific training that GSA has. I would encourage you to go through the toolkit and find the different resources around brain health in both the regular toolkit and this one. Is there a way to find nursing facilities that are designated as dementia friendly? There is no dementia friendly nursing home designation that I am aware of. It's not to say it doesn't exist, but a nursing home can call themselves a dementia care center. There is no what is the standard that leads to that? There's no measurement around there. There are, at least there used to be some certifications that you could be a whatever type of provider. I am not aware of kind of the processes around them or anything. Honestly, if I was considering a nursing home for a loved one, I would be walking the halls and talking to the staff, and that's how I'm going to learn how dementia friendly they are. Nothing replaces a tour in a nursing home. And I don't want to just go to the fancy new wing with the chandelier. I want to hit every wing. And if there's a reason they won't let me on one wing, I'm probably not going to that nursing home.
Yeah, and Jen has been kind of collaborating a lot in Ohio. You guys probably don't even realize the amount of kind of work and resources that we have been doing in Ohio. I certainly didn't understand that the county board system in Ohio is pretty innovative, and I know Jen has already done it. But there is a really great ongoing group that we're looking for more members. I'll put information about it in the chat box in a minute, but you can, if you wanted to represent your county on that. I mean, if you're here, you're probably interested in this population, and we're always looking for more people. And it's run through, it's called the CARI group, CARI, and it's collaborative for adult resources. I can't remember what the I is, but it's funny. It ended up being, it's getting to be more in the aging talk a lot is what we're doing, planning for the future, aging, dementia. And we have some great counties represented on that group. We have Franklin County, Summit County, Lucas County, Hamilton County, Butler County. So, and then we have lots of other area office on aging and Down Syndrome Association, all kinds of other people. So we have monthly meetings. We'd love to have more people. And it's Ann Tapia from the Department of DD that kind of runs that group. But the dementia friendly word, which I know Corey put in here, that is a big deal for counties. Like Summit County is becoming a dementia friendly county, which means they're doing all kinds of work. I think Lucas County has put some work towards that, and they've done some really good stuff. So lots to learn. Okay, Corey, go ahead.
Corey, I want to just clarify, it wasn't dementia friendly facilities, it's dementia friendly communities, as in
Yes.
towns and counties and neighborhoods.
Yeah.
And so the group that leads that is the Ohio Council for Cognitive Health. So if you go to their website, they can give you more, but Summit County in particular is one I know that has done great work in that area. I did a presentation at their library. And so their library is like a hub. It's really, they do a really pretty cool job. And a lot of the groups in Ohio really take this approach that are working in dementia. take this approach to, it's got to benefit everybody in the community. So if it just benefits the doctors or whatever, well, then why should the library and the Department of Corrections and the post office and other people want to get involved? So they really make like this community groundswell, and that's how they get that done. So let me see. Okay, Corey, I think we got you. Okay. Whitney has a question. I recently encountered a man that was in a rehab hospital with combative dementia, kept on 24/7 physical and chemical restraints. How can we better advocate for our people that could be considered difficult people? Great question. Take a look at our agitation and Alzheimer's information. We actually have a care pathway that addresses, looking at what are some, understanding what's happening with the behavior, and then looking at how do you then address that behavior from a non-pharmacological standpoint. There are times when pharmacological management's necessary and appropriate, but there should be a whole bucket list of stuff that's been done first before moving to that. And then importantly, when the pharmacological management starts, all that non-pharmacological stuff shouldn't be going away. It should be continuing. And the other thing I think we talk a lot about is when we consider life in a care setting or any setting, it could be a home or community-based service setting too. When we look at someone who has a behavior, we look at the success of treating that behavior as simply the absence of the behavior, where I would argue the real success of treating that behavior is that they can engage in their daily life. They can now sit and eat their meal. They can now converse with a family member. They can now engage in an activity. They could read their paper that they like to read. That's the success of managing agitation or some of these other behavioral and psychological symptoms of dementia, is that they get to engage in something that those behaviors are preventing them from engaging in. And we're really, I'm from the world of nursing homes. So when I say they're doing a bad job, I say we're doing a bad job. We always did a bad job of capturing the essence in our documentation of what that meant to the individual and their loved ones. So I think that's a really important point.
Yeah, I love that. Thanks, Jen. That's a great answer. I think probably the biggest, I think another thing is just to think about preventative measures. I think one thing I've learned since I've started attending more things and trying to learn more about dementia, Alzheimer's, all that, is this whole philosophy of kind of the stay in place idea that, we want to, what age in place, maybe it's age in place is the name, that anybody that's potentially showing signs of that, you're going to find a lot more success by not having them have to change where they live. And so I've heard more and more from a county board perspective, like, let's not just go. It is very difficult to take care of people in their own home, but the longer you can do that, the less difficult they might be. When you make major moves of locations, that's going to often escalate things. So again, Lucas County doing some actual trainings around the age in place idea, and talking to providers, our direct service professionals, not medical providers as much, but the people that are supporting our people. How can we keep them in the house? What could we be doing with the providers ahead of time and helping them and supporting them so that we don't have to look for nursing home placements or, moving them into another home with 24/7. So just my two
thing
bits.
I'll mention is take every opportunity when there is a behavior or some kind of problem, something we see as a problem, take the opportunity to kind of do a debrief on that, right? What just happened? What were the triggers? It happens again. What was common in this one and that one? And it might be a caregiver, might be somebody who looks like, the ex-girlfriend of their husband or something, right? It might be somebody who they just are never going to like because they think she's somebody else. Or it might be someone who is, the way they talk reminds them of something. Or it might be that they hadn't yet had breakfast when they tried to do their care that day, and they really feel better after breakfast. And so really taking that opportunity to do that kind of, Monday morning quarterback of what just happened here and how can we then do something different to prevent it. So we want to take that proactive approach and not just that reactive approach to behaviors. And I think that's a real a really, really important part of behavior management. And
Yeah,
also
I was on
understanding a
some,
lot of times behaviors are an unmet need, right? Something's going
yeah,
on. I think of the great example of a resident he was a wanderer. He wouldn't stay where he was parked, in his wheelchair, which he shouldn't be parked in my opinion anyway, but he wouldn't stay where they wanted. Well, the aide finally said, well, he likes to sit under the skylight. He's always cold. So he was, taking off from where they wanted him to be to go sit under where he wanted to be, which was under the sunshine. And so, but that was a problem, that was a behavior. So I think we want to look at that a lot differently than we perhaps do. And Lisa says, look at Dementia Friends. Absolutely.
yeah, I have a ton of resources. So, you can feel free at OACB. If you have questions and you're looking for some supports, reach out to me directly at OACB. I probably have the most related to, aging, dementia, Alzheimer's. But it's just amazing the stuff that we're learning about. We've been working with NTG, the National Task Force for folks who've been working with this Dementia Friends, and I'm trying to think, what is it? I always call it the wrong thing. Help me out, Jen. Ohio Council
Council
for
for
Cognitive
Cognitive
Health.
Health. Yep. They're wonderful.
That's the main one I would like always go to, and then they route you to lots of
Yep.
other things.
Yeah, they're a terrific organization. We collaborate with them happily as often as we can. The other thing I haven't mentioned is the cost of all of our tools and resources, and that is absolutely nothing. They are free. All we want to do is make sure you get them in your hands and into the hands of others who can use them to help the care of adults and older adults. And again, there's lots of different topics. I mentioned our obesity work. We have a lot in that, a lot around oral health. That's certainly a huge issue. And lots around vaccines too. And we really focus on increasing the reverence for vaccines. So we don't want to talk about hesitancy or acceptance. We want to talk about reverence. Why is it so important? Why is it such a miracle that we have these things that can prevent illness? So lots of great resources there.
And if again, I have great communication with Jen. She is I have quite a few of the hard copy, print copy of the CARE Toolkit. I again would only want to give one or two of those to each county. It's just an idea, but really it's going to stay most up to date with the online links. And Jen is happy to do, if you had kind of folks in your community, whether they were medical professionals, providers, direct service providers, families. I mean, we could set up some regional virtual chats about some of this stuff if we knew who the audience was going to be. And OACB is happy to help organize that. So whatever we can do to get this CARE Toolkit out, we'd be really excited for more people to be using the original one as well as the companion one.
Yeah, absolutely. Any other questions from anyone? I knew you guys were going to be a great group when you answered my question right away when we started the program about have they checked your brain. Hopefully you'll ask in the future, how do you check my brain? You check my heart and my lungs. Why don't you check my brain?
Yeah, I have, since I've met Jen and I've been learning so much more about it. I go in and I can tell you the way to do it is not to slough off that you can't remember anything like that. Because me, given my age, they'll say, do you have any other concerns during my well check? And I'll be like, well, like I might have an attention span of a gnat and I can't remember anything. That's not specific enough to get them to really be talking about it. You definitely want to actually give them some resources. When I went back the next time and said, hey, I want you to take a look at this, it might be helpful with lots of people. Sure enough, that made a really good impression. So
nice. And nice comment from Caitlin. Thanks, Caitlin. I'm glad you found it helpful.
Awesome.
Great.
Well,
thanks, everybody. Enjoy the rest of this summer. If you're having I'm in New York. If you're having the heat we are in New York, there in Ohio, it's pretty brutal, but they tell us a little relief is on the way. So once you get the relief, I probably will get it the next day. So, all right. Be well, guys. Awesome. And thank you so much. Well, thanks, Alicia. Appreciate it.
Yeah, absolutely. And so just a reminder to anybody still on, look for an email from OACB to have you checked in. You'll complete the evaluations. I'll share those with Jen. You'll get your CPDUs if you have any problems. That's training at oacbdd.org, or myself, Lisa Combs, L. Combs at oacbdd.org. Also, we are considering putting up a recording. So when you are thinking, man, what did I do with that link they gave me? It is in the OACB Member Connect document center under trainings and events. We'll have the PowerPoint and the resources that I shared at the beginning of this. And if we have a recording, there will also be a link to the recording of the session there that you can share out. Otherwise, have a great rest of your week. Enjoy, and don't forget to share about the CARE Toolkit to anybody who will listen. It will be great.
There's a good plan. All right. And a good
All
way
right.
to end. Thanks, Lisa. Take care. Thank you all so much.
Thanks a lot.
Be well. Bye-bye.
Talk to you later. Bye-bye.